So with great fanfare, obviously, it's a great pleasure to welcome everybody to this evening's ESO Guideline Webinar, at which we'll be discussing two ESO guidelines on the topics of Moyamoya angiopathy and Tenecteplase in stroke. We've got a panel of expert speakers who will introduce the background and the guidelines and go through these over the coming hour. We will be assembling questions and have those addressed in the Q&A session at the end. Please feel free to type any questions you have into the Q&A box on the Zoom facility, bottom part of the Zoom window. These won't be addressed during the presentations, but we'll gather these together and have that as part of the discussion for both topics at the final session of this evening's webinar. I should also finish by also noting that the guidelines will be published in the European Stroke Journal, and there'll be QR codes linking you to those publications presented at the end of the meeting as well. It's a great pleasure to be co-chairing this with my colleague Diana Aguiar de Souza, and I'm going to hand over to Diana to introduce our first speaker.
Thank you, Keith. Also from my side, warm welcome, and thank you to all participants for joining us for this another exciting ESO Guideline Webinar. So it is now my great pleasure to introduce our first speaker. Professor Vieira Ganzan is pediatric neurology at Great Ormond Street Hospital, London, where she works in a comprehensive multidisciplinary team managing childhood cerebrovascular disorders, including a specialist service for Moyamoya disease. Her research interests have focused on the causes and consequences of childhood stroke. She was chair of the 2017 Royal College of Pediatrics and Child Health Childhood Stroke Guidelines Committee. And Professor Ganzan will talk about Moyamoya vasculopathy, epidemiology, clinical presentation, and natural course. Thank you very much for joining us, Professor Ganzan. We look very much forward to hearing your presentation. Thank you.
Thank you very much for the kind invitation to ask me to talk today, introducing the Moyamoya guidelines, and I will try and cover some of the topics listed here. So as we all know, Moyamoya is a cerebral arteriopathy, and I've put here current definitions. And I think the important concept I wanted to get across is that this is a radiologically defined disorder, either by catheter angiographic studies or MRA. And I think this is really conceptually important because my way of thinking is that we're really talking about a radiological signature that likely represents a number of pathological and pathway processes. And I suppose one of the themes of what I'll be discussing is whether it makes sense to consider this as a single disease entity or whether we need to take a more patient-specific approach. So some of the uncertainties I think there are whether Moyamoya is really a homogeneous or heterogeneous disorder, and whether the disease phenotype varies according to ethnicity. We all know the preponderance in East Asians, but those of us working in Europe will mainly deal with patients who are not from, East Asia. Most of us will not be dealing with East Asian patients, and the question is really whether we're dealing with the same disease entity. Whether the clinical presentation and particularly the natural history is the same for all patients with this radiological phenotype, and whether a genetic basis is an important disease biomarker. I think as clinicians, it's also important to understand what other important biomarkers there are of natural history. So when we see an individual patient, can we predict what patients are likely to be stable, what patients are likely to be progressive? And so are we able to generalize from large studies, predominantly from East Asia, to the individual patient we're seeing in a clinic? And then finally, for a disease that has a plethora of papers focusing on surgical interventions, are we able to say anything about the optimal medical and surgical approach in an individual patient? So I've put here some of the estimated incidences, and really the main point here is that This is a disease that's very common in East Asia. But it is obviously, as we all know as clinicians, not unknown outside. And I think the point of asymptomatic cases is really important, because I think the incidence perspectives are really only likely to represent patients who present symptomatically. And certainly in East Asia, there are a lot of patients who are identified on population-based studies who have not presented clinically. We did a UK-based cross-sectional study surveying tertiary pediatric neurology centers. So this is only pediatric cases, and identified 95 patients in this cross-sectional study. So that gives you some idea of the prevalence in the UK. We all know that this is a condition which has a bimodal distribution. So I mainly deal with children with ischemic events, predominantly stroke or TIA, but there is also another peak in young adulthood, in early young adulthood, and the specific age range seems to vary a bit between Asian studies and European studies. But this is a cerebrovascular disorder that can present with focal deficits, as well as all these other entities that I have listed. And again, I draw your attention to this asymptomatic group. Ischemic presentation. So I think it's interesting to consider whether stroke presentations, so ischemic stroke or TIA, are the same thing. My clinical experience is that the clinical phenotype tends to run true. So children who present with ischemic stroke tend to have recurrent strokes, whereas those who present with TIA, whether or not they have changes on brain scan, tend to then have recurrent TIA. So, I think the presentation is important. Cerebral hemorrhage tends to be more seen in older patients, and it's well known that rebleeding is common. I've followed patients now for nearly 25 years, and in the pediatric cohort, it is unusual for children who present initially with ischemia to then develop brain hemorrhage, but this is by no means never seen. It's just unusual. So there's very little data from natural history studies, and this is a very old study now looking at untreated patients with IQ on the y-axis and duration of illness on the x-axis, really showing progressive cognitive decline. And the older papers really, East Asian studies again, suggest a very progressive and malignant clinical course. And this is really what has fueled the enthusiasm of the surgeons. Undoubtedly, in the context of childhood arterial ischemic stroke, Moyamoya is the most malignant radiological signature. So presence of an arteriopathy highly predicts recurrence. And of these, in a separate study, it's been shown that the Moyamoya signature in particular is strongly predictive of recurrence. However, if you look at this in the context of these are data where people in a captive population in Japan were all scanned, and nearly 20% of people identified with Moyamoya were essentially asymptomatic. So it really begs the question of whether there's a one-size-fits-all approach, or whether actually we need to understand the underlying disease basis and biomarkers in individual patients. I think there are important clinical biomarkers, and I don't think we should really dismiss clinical observation. So my gut feeling has always been that children who present very young, so under the age of 5, do badly. These are data from 31 children. Each horizontal line is an individual patient. Each triangle is an event. The x-axis is time. And really what you can see here is that these children present with a refractory and recurrent clinical course, which is often refractory to surgical intervention. Here you can see that these are patients, again, time here, free from recurrence here. So this is using the childhood cascade classification. And really there are 2 points I want to make here. So both of these groups of patients have bilateral cerebral arteriopathies. These are patients in the solid line, patients who meet strict criteria for Moyamoya, essentially those with collaterals. These are patients with bilateral disease without collaterals. You can see that both have an appreciable rate of recurrence, but there's something about the strict radiological criteria that pick these patients out to be at higher risk. And I think actually the development of collateralization probably reflects higher ischemic drive. I think it's important to note that your standard clinical radiologist will probably report both these groups of patients as having Moyamoya. I don't think radiological reports are always that sort of a perfectionist. So I think it is important to have some sort of gut feeling of what the features are that may indicate a better or worse prognosis. So moving on to other phenotypic sort of biomarkers. This is an interesting story. So ACTA2 encodes for alpha-actin, which is a component of vascular smooth muscle. And patients with this mutation who had the most severe multisystem phenotype were initially described as having Moyamoya. If you go through the papers, Moyamoya is said to be a feature, but actually they have very distinctive phenotype. So in contrast to the terminal carotid stenosis and collaterals here, patients with this mutation reproducibly have proximal vessel ectasia, distal stenosis, no collaterals, and this rather straight appearance of the brain arteries, and this rather leukaryotic appearance in the white matter. And this is just meant to give you a gestalt for these images from 13 patients, how reproducible this signature is. Does this matter clinically? I think it does. These are patients who have multisystem disease. In my experience, these patients are exquisitely sensitive to hemodynamic disturbance, so they really do not tolerate fluctuations in blood pressure, say with vomiting, dehydration, etc. And they're patients who don't tolerate surgery or arterial instrumentation very well. So I think it's important to recognize these subphenotypes so that we can manage these patients appropriately. So the genetics is a complicated story, but undoubtedly the genetic linkage studies in East Asians suggest different loci important than in non-East Asians. The RNF213 story is interesting. So this is a gene that confers susceptibility. And recently, the concept of RNF213 associated vasculopathy has gained credence. So in other words, that Moyamoya is at the tip of the iceberg of arteriopathy associated with this gene, which may actually also be linked to other, perhaps less severe phenotypes. I'll just illustrate that in a minute. There are monogenic associations, neurofibromatosis type 1, trisomy 21, etc. The lists are in many books. These are some of the more recently identified genes. And I think an important point is the systemic association. So not just for genetic counseling, but also for disease surveillance, both in the affected individual and in family members. So I think this is taken from this excellent paper by Ihara et al. Published last year, which really, I think, summarizes the concept I'm trying to get across, that Moyamoya is not a single disorder, but can arise from disturbances in many pathways encoded by genes all across the spectrum of vascular homeostasis. And so I think, certainly if we're looking at molecular interventions, I don't think there is going to be a one-size-fits-all model. And this also really explains why systemic associations are so important. I don't expect you to read this. This is a free download, but in this review paper, Nadine McRae really helpfully summarized some of the systemic features in a patient with arteriopathy that may point you to an underlying genetic diagnosis, but also if you have a patient with one of these identified genes, what other systemic disorders you may need to look for. And this, I've taken this from Ihara et al., but really illustrates the point about RNF213 associated vasculopathy. So you can see here asymptomatic patient with unilateral stenosis, bilateral stenosis, no collaterals, and a patient with more typical Moyamoya. And essentially, I think this is quite a really useful concept, because I think it is likely that many of these genes will manifest in terms of a widely varying phenotype. So when we're thinking about Moyamoya, some of the observations we make are likely relevant to patients with less strict meeting less strict radiological definitions. So these are sort of entities I see commonly in my practice as a pediatric neurologist: unilateral stenosis, bilateral stenosis, no collaterals, but we haven't really explored the relevance of RNF213 in that pediatric population. I think that's going to be an important study. So moving on to treatments, I'll show you some data about antithrombotic treatment in a moment, conventionally antiplatelet agents. But in clinical practice, I think the most important thing and helpful thing we can do for our patients is ensure good fluid and blood pressure management. And this is something that doesn't receive much attention. It's a very, unsexy intervention, but I think ensuring hydration, supporting the blood pressure, and particularly not letting people drop blood pressure, because 20% will have concurrent renovascular disease, is actually practically really important. Surgery is the kind of sexy intervention. And it's very difficult to interpret the data because, all surgical papers really say that operations work, but that's a bias that we know about the surgical literature. The indications vary between centers. It's very difficult to evaluate the efficacy, and I don't think there's ever going to be a trial. Our data, I'll show you our data in a minute, but we have been offering surgery for the last 20 plus years in patients who show a tendency to recurrence, so more than one clinical or radiological event. So this is the paper looking at antiplatelet agents, suggesting that antiplatelet agents are helpful. And I think this is a useful study because we have rather blindly been using antiplatelet agents in this condition. And these are the Japanese guidelines 2021, really recommending surgery in patients with ischemic symptoms. But you see the level of evidence is actually very low. I'm not actually going to go through the whole recommendations, other than to say it's quite interesting that thrombolysis is recommended in the context of ischemic stroke. I think this is somewhat different from other sets of guidelines. And finally, that hemorrhage is actually an indication for surgery, and the level of evidence is perhaps somewhat higher. So these are data from the 94 children I was talking about. So it's a cross-sectional UK-wide study. And these are basically predictors of outcomes. So we're looking at dichotomized outcome, good versus poor, looking at the good being defined as the Rankin score plus school performance. And you can see some of the predictive variables here. But what was really interesting was that surgery was not predictive of prognosis. Now, I think there are many complicated reasons for this, but I think, I would really take with a pinch of salt that surgery is a universal panacea for this condition. I think you need to pick your patients properly. So I'm going to finish by saying that Moyamoya is, in my view, really not a single disorder and likely not to have a single magic bullet. I think the genetic basis and the clinical features likely determine natural history. And I think that's important to consider when you're sitting in front of a patient. The role of both medical and surgical interventions is, I think, uncertain and likely really only to be able to be reached by consensus and standardization of practice, because I think it is very unlikely that we will be able to mount randomized clinical trials. Thank you very much.
So thank you very much indeed, Vijaya, for that excellent presentation. That's a very, very interesting review of current state of knowledge. My task now is to introduce our second speaker on the topic. Dominique Hervé is a vascular neurologist who is responsible for the Reference Centre for Rare Vascular Diseases of the Brain and Eye at the Hospital Lavoisier in Paris, and also coordinator for the Neurovasc working group dedicated to rare cerebrovascular diseases, including Moyamoya within the European Reference Network on Multisystemic Vascular Diseases. He is the co-chair of the module working group for the guidelines, and he's going to present on Moyamoya angiopathy with respect to the ESO guideline. Dominique, thank you.
So our module working group was chaired by Anna Bersano and myself. And was composed of 10 experts in cerebrovascular disease, including 6 vascular neurologists. As you know, Moyamoya angiopathy is a rare condition with multiple questions for stroke neurologists. The natural cause is not well known. The prognostic value of vascular and hemodynamic assessment and the need of long-term imaging assessment is undetermined. The pathogenesis is poorly understood. Even we know that there is a strong genetic component in MMD cases related to the RNF213 gene, but we do not know the prognostic value of RNF213 variants. There is no treatment reducing the progression of the disease, and the efficacy of aspirin for reducing ischemic events is undetermined. There is a lack of guidelines for cerebral revascularization surgery, which is used to prevent clinical manifestation. We do not have a clear indication criteria. We do not know what is the best technique of revascularization. We do not know what is the best timing for surgery. And we do not know what is the best patient management during the perioperative period. For developing these guidelines, we follow the ESO procedure, which is based on the grade evidence methodology. We identified 9 PICO questions. 3 were dedicated to imaging assessment. 1 was dedicated to the genetic screening of RNF213, and 5 were dedicated to medical and surgical treatment. We identified and rated the main outcomes, and we performed a systematic review of literature for each PICO question before grading the evidence. And an expert consensus statement was provided when there were insufficient evidence to provide a recommendation. So now we will start. First PICO question concerning hemodynamic assessment. In patients with Moyamoya angiopathy, does hemodynamic assessment using the different techniques compared with no hemodynamic assessment improve the identification of patients at higher risk of unfavorable outcome? We had insufficient evidence to provide any recommendation, and the expert consensus statements were as follows. For all patients, we suggest performing hemodynamic assessment during the diagnostic workup in order to help decision-making. In patients with asymptomatic MMA and where symptoms are not clearly associated with hemodynamic triggers, hemodynamic assessment should be performed to identify hemispheres at risk. For patients with clear hemodynamic triggered TIAs or water-shot stroke in one cerebral artery territory, perfusion studies should be considered to identify at-risk asymptomatic brain territories. And finally, we suggest to use imaging methods most familiar and available depending on individual institutions. PICO 2. In patients with MMA, does the assessment of involvement of posterior circulation compared with no assessment improve the identification of patients at higher risk of unfavorable outcome? We could also not provide here any recommendation, but in children, we suggest assessment of PCA or posterior circulation involvement to identify patients at higher risk of stroke and cognitive impairment. And we suggest the same method to be used, but to identify patients at higher risk of ischemic or hemorrhagic stroke. PICO 3, in patients with MMA, does genetic testing of the RNF213 susceptibility variants compared with no genetic test improve the identification of patients at higher risk of unfavorable outcome? There is no evidence for any recommendation, but our expert consensus statement is, regardless of ethnicity, we suggest against systematic screening of the most frequent variant of RNF213. What about antiplatelet therapy? PICO 4. In patients with MMA, does antiplatelet therapy compared with no antiplatelet therapy reduce the risk of an unfavorable clinical outcome? Only the following expert consensus statement was provided. suggesting the use of long-term antiplatelet therapy to reduce the risk of embolic stroke in patients with non-hemorrhagic presentation. Concerning now the surgical treatment, PICO5, in patients with MMA, does revascularization surgery compared with no surgery reduce the risk of an unfavorable clinical outcome? We could here provide a recommendation only for adult patients with hemorrhagic presentation. And our recommendation is, in adult patients with hemorrhagic presentation, we recommend revascularization surgery in case of cerebral hemodynamic impairment and in presence of choroidal collaterals. The quality of evidence is low and the strength is weak. This recommendation was based on the only one RCT available in Moyamoya angiopathy, which is the GEM trial. 80 adult patients were included and randomly allocated to medical treatment or combined revascularization surgery on both sides. A lower rate of recurrent cerebral hemorrhage was observed in the surgical arm, but the quality of evidence of this study is low due to no blinded allocation of participants, the optimal size which was not met, and the limit of significance. Outside the hemorrhagic presentation, we also had expert consensus statements, and for this important question, we obtained a full and consistent agreement among the voters. For all patients, we suggest that surgical revascularization is performed in a referral center and by a neurosurgeon with significant experience in surgical revascularization techniques. In adult patients with ischemic presentation, we suggest revascularization surgery in case of clinical symptoms and or imaging markers of hemodynamic impairment. And in asymptomatic patients, we suggest conservative treatment except in patients with both cerebral hemodynamic impairment and silent ischemic lesions in the same cerebral region. And for pediatric patients, we suggest revascularization surgery when evidence of ongoing ischemic symptoms or cerebral hemodynamic impairment. In support, we have 5 observational studies comparing revascularization versus conservative surgery in adult ischemic MMA. The meta-analysis that we did evaluating the risk of any stroke showed, as you can see, a clear trend in favor of surgery. But this is important to note that all these studies had several limitations. Regarding the revascularization techniques now, PICO6. In patients with MMA, does revascularization surgery compared with no surgery reduce the risk of an unfavorable clinical outcome? There is no evidence for any recommendation here, but this is our expert consensus statements. In adult patients, we suggest direct or combined revascularization instead of indirect strategies for reducing the risk of stroke. And in pediatric patients, we suggest combined revascularization instead of indirect strategies whenever technically possible to decrease short-term risk of stroke. In support, we have 5 observational studies comparing direct or combined versus indirect revascularization in adult MMA, and the meta-analysis evaluating the risk of any stroke showed a clear trend in favor of direct or combined revascularization. But again, these studies had several limitations. Antiplatelet continuation during surgery, PICO7. In patients with MMA, does discontinuation compare with continuation of antiplatelet therapy during the revascularization procedure increase the risk of an unfavorable clinical outcome? No evidence, of course, but we suggest during bypass surgery, continuation of antiplatelet treatment as monotherapy is safe. In case of discontinuation, we suggest restarting antiplatelet therapy 1 to 7 days after surgery, depending on the post-surgery CT scan. In case of dual antiplatelet therapy, we suggest stopping the other second antiplatelet therapy for 7 days before surgery. In practice, what about the time interval between stroke and surgery, GO8? In patients with MMA, does respecting a 6 or 12 weeks minimum time interval from an acute cerebral vascular event to revascularization surgery compared to earlier and or immediate surgery reduce the risk of an unfavorable clinical outcome? We suggest waiting 6 to 12 weeks from an acute cerebrovascular event before performing surgery to reduce the rate of postoperative complications, to avoid trigger factors such as dehydration, fever, and hyperventilation, as well as hypotension when waiting for surgery. In children, we suggest that waiting for surgery should be balanced against the risk of further stroke. And in these pediatric patients, we suggest that early surgery could be considered for those with recurrent TIAs, single or recurrent ischemic strokes, if there is a rapid and complete clinical recovery. Moving now to the long-term follow-up after conservative or surgical treatment, PICO9. In patients with MMA, both after surgery and with conservative management, does long-term follow-up neuroimaging assessment compared to no follow-up assessment modify the clinical practice in terms of medical or surgical treatment? Our consensus statements was as follows. We suggest long-term neuroimaging follow-up to evaluate the progression of the angiopathy. In case of unilateral MMA and conservatively managed patients, neuroimaging assessments should be carried out. Neuroimaging follow-up should include at least MRI, and hemodynamic evaluation. DSA should be performed preferentially when a vascular chain is suspected and the therapeutic decision is to be made, or when non-invasive techniques are not conclusive. Finally, we suggest that the timing of follow-up assessment should be individualized. To conclude, this is the third guideline on the management of MMA using grade methods. As you can see, we found an overall paucity of data on diagnosis and effective treatment approach. We found mostly observational studies, and only one specific RCT was available. Finally, we provide one evidence-based recommendation with low quality of evidence on surgery and non-expert consensus statements. Thank you very much for your attention.
Thank you very much, Dominique, for the concise presentation, and congratulations to you and the model working group for completing this challenging but definitely very useful guideline. I should now introduce our next speaker, Professor Alamovic. Sonia Alamovic is Professor of Neurology at Sorbonne University since 2009 and head of the Neurovascular Emergency Department at the Salpêtrière Hospital in Paris. Her research interests include treatment of acute ischemic stroke and rare causes of stroke, and she is the principal co-investigator of the French Tenecteplase registry, TETRIS. She has been president of the French Neurovascular Society since 2022. Professor Alamovic will present the ESO expedited recommendation on Tenecteplase for acute ischemic stroke. Thank you very much. The screen is yours.
So, thank you very much for this introduction. Can you see my full screen? Yes? Cool. So this is my great honor to present today the ESO expedited recommendation on Tenecteplase for acute ischemic stroke. All disclosures can be found in the publication, and our module working group was chaired by Giorgio Tsipoulis and myself, and was composed of 11 members, 9 participants in the vote, and 2 fellows. So to start, a few words on Tenecteplase. Tenecteplase is a genetically modified form of alteplase associated with a longer half-life and higher fibrin specificity. The administration of Tenecteplase is easy with a single bolus in 1 minute, and this could have advantages in the setting of an acute ischemic stroke, about the door-to-needle time, about the transfer of patients, but it is not the most important. The crucial point is about the efficacy and safety data of Tenecteplase comparing to alteplase. We had several phase 2 studies comparing Tenecteplase with alteplase, and the question of Tenecteplase was addressed in the last ESO recommendation on intravenous thrombolysis. And as you know perfectly well, when intravenous thrombolysis is indicated, Tenecteplase 0.25 milligram was suggested over alteplase only for patients with large vessel occlusion, but not for patients without large vessel occlusion. Quality of evidence low, and strong of recommendation weak for both populations. Last year, 4 published randomized control trials comparing Tenecteplase and alteplase, and another trial reported at a congress. Thus, it was the right moment to provide a new recommendation. A few words about the methodology. I will not detail this point. We strictly followed the ESO standard operating procedure with the grade approach, and we formulated our PICO questions in 3 different populations. PICO 1 in all patients with acute ischemic stroke of less than 4.5 hours. PICO 2, same time window, but also a large vessel occlusion, and PICO 3 for wake-up stroke and stroke of unknown onset. About the intervention, 2 treatment options were analyzed. Intravenous Tenecteplase at 0.25 milligram kilo and Tenecteplase at 0.40 milligram kilo. The comparator was the standard treatment, so intravenous alteplase. Let's now look at briefly the outcomes of interest. We identified and rated 14 outcomes for patients with acute ischemic stroke, and 17 for those with also large vessel occlusion, and we voted for rating of the importance. The 2 outcomes at the top of the list were ranking 0 to 1, so an excellent functional outcome, and ranking 0 to 2, a good functional outcome at 90 days. But for patients with acute ischemic stroke, the primary outcome was ranking 0 to 1, and for patients with LVO, the primary outcome was ranking 0 to 2. And we also analyzed several critical and important outcomes common at both populations, such as mortality, intracranial hemorrhage, time metrics, and finally, for population with large vessel occlusion, we selected also as an important outcome the recanalization rates. A brief methodological point about the non-inferiority margin. Our analysis of the primary outcomes were performed with a non-inferiority design. And you know that to demonstrate non-inferiority, the lower boundary of absolute difference must be above this margin. And this is a figure from Guillaume Turc. And to define this margin, we also voted to choose this margin for the two main populations. First, for all patients with acute ischemic stroke, the margin was set at 3%, and 7 voted for this 3%, and 2 votes for more stringent margin. For patients with large vessel occlusion, the margin was set at 1.3% for all the members, and it was to be consistent with the guidelines on bridging therapy. Let's move on to the result with the first PICO. So it's acute ischemic stroke of less than 4.5 hour duration. And it's a comparison between Tenecteplase 0.25 milligram kilo and Alteplase with the different outcomes. And we performed a non-inferiority analysis for the primary outcome. Due to a short time, just a rapid comment about the 7 studies included in our analysis. Of these 7 studies with patients treated with Tenecteplase 0.25 milligram kilo, the majority was phase 2 study. The only strictly phase 3 study, including the large number of patients, was the Canadian ACT study published last year. And as you can see, the risk of bias of the study was generally considered low for most criteria. Let's see now the main results. So for these populations, it is the meta-analysis for the primary outcome, ranking 0 to 1. And as you can see on this forest plot, the unadjusted risk difference was at 3.68%, and the lower boundary at 0.32%. So it is above the non-inferiority margin of 3%. It's also above the over option for the margin of non-inferiority. So the conclusion of this analysis, it is that the non-inferiority is demonstrated. For the ranking 0 to 2, same population, same treatment, and same conclusion. It is also statistically significant. It is non-inferior to Alteplase. And for the safety data, the rate of intracranial hemorrhage and the mortality at 3 months, you can see that we did not detect any significant difference. So finally, also for the time metric analysis, door to needle time, symptom onset to needle time, very few data, a trend in favor of Tenecteplase, but it was not statistically significant. So this is our evidence-based recommendation for this population, and for Tenecteplase 0.25 milligram kilo, it can be used as a safe and effective alternative to Alteplase, and the quality of evidence moderate, strength of recommendation strong. We provided also an expert consensus statement, and the group suggests favoring Tenecteplase 0.25 milligram kilo over Alteplase in light of safety and efficacy data, and because Tenecteplase can be administered with a single bolus. And 9 members voted for this statement. Briefly, the next question, same population, but with Tenecteplase 0.40 milligram kilo. This is the primary endpoint, ranking 0 to 1, and you can see the forest plot. And the risk difference was at minus 7.45%. So clearly, non-inferiority for this dose was not demonstrated. And about intracranial hemorrhage, the rate tend to be higher for Tenecteplase. So our recommendation, we recommend against using Tenecteplase at the dose of 0.40 milligram kilo, quality of evidence low, strength of recommendation strong against intervention. We have also a recommendation for patients managed with a mobile stroke unit. This is the data from the taste A, and it's about Tenecteplase 0.25 milligram kilo. Our recommendation, we suggest Tenecteplase 0.25 milligram kilo over Alteplase to increase the rate of early reperfusion and to shorten the time from imaging to treatment initiation, low quality of evidence, and strong of recommendation weak. Moving to PICO-2, patients' semi-time window, large vessel occlusion, and a comparison between Tenecteplase 0.25 milligram and Alteplase. The primary endpoint, ranking 0 to 2, and you can see the forest plot and the unadjusted risk different at 16.15%. And also the boundary is above the non-inferiority margin, which was at 1.3%. So the non-inferiority is demonstrated. The odd ratio for the ranking 0 to 1 in this patient with LVO, same results in favor of Tenecteplase. And about the safety data, the rate of symptomatic intracranial hemorrhage and the mortality, it is not statistically significant and perhaps a trend in favor of Tenecteplase. And finally, in this population, we also have a judgment about the recanalization rate before mechanical thrombectomy and at the end of the mechanical thrombectomy, and a trend in favor of Tenecteplase, but not statistically significant. Our recommendation for this patient, we recommend Tenecteplase over Alteplase. Intravenous thrombolysis should not delay mechanical thrombectomy, and quality of evidence moderate, strength of recommendation strong. We also provided an expert consensus statement voted by all members in favor of Tenecteplase, both patients directly admit to a thrombectomy center or not. A few words about patients with wake-up stroke or with stroke of unknown time. First, PICO in this population, the comparison between Tenecteplase 0.25 milligram and no thrombolysis. The recommendations is based on the twist result reported at the ESO last year and published last week. And our recommendation, so for wake-up patients or with unknown stroke onset, if these patients are selected with no brain imaging other than planned CT, we recommend against intravenous thrombolysis with Tenecteplase 0.25 milligram. Strong against intervention, quality of evidence low. And last question, wake-up stroke, unknown onset. Tenecteplase compared with Alteplase. Finally, in this population, we do not have any trial. So our evidence-based recommendation is there is a continued uncertainty over the potential benefits and harms of Tenecteplase compared with Alteplase. But we decided to provide an expert consensus statement, and all members suggest that Tenecteplase 0.25 milligram could be a reasonable alternative to Alteplase after selection of this patient with advanced imaging. So we are clearly in line with the last recommendation in this population. So My conclusion, take-home message, the two important recommendations, and this is clearly new for this patient, for all patients who are eligible for intravenous thrombolysis. And for patients with large vessel occlusion, this is the same recommendation as the last intravenous thrombolysis, but we upgraded the strength of recommendation and the quality of evidence. Few comments to discuss, as you know, the issue about the shortage of Tenecteplase in Europe, the appropriate packaging not adapted for stroke, the regulatory aspect and the perspective. It's very important, the next frontier of Tenecteplase in stroke, and it is the following talk. Thank you for your attention.
So thank you very much indeed, Sonia, for that comprehensive review of the updated recommendations in Tenecteplase. That's very thorough and clear. Can I introduce our final speaker for this evening, Professor Bijoy Menon, who is stroke neurologist and involved in both neuroscience and radiology at the University of Calgary, whose interests are particularly focused on advanced imaging methodologies in acute stroke, but who has also been the lead investigator of the ACT trial, which has been a main informant of the updated guidelines. Pleasure to have Bijoy looking at the future perspectives for Tenecteplase. What do we expect to do next? Bijoy.
Well, thanks, Keith, and thanks everyone for your time. I'm sharing my slides. Can you see them and can you hear me? Thank you. Let me put it on. Okay, so these are my disclosures. Tenecteplase use is still off-label, currently for acute ischemic stroke. So it is surprising, and you know, we're always wonderstruck by looking at this slide. It's almost 100 years since the first thrombolytic agent was known to us, to man. But it was since the late 1990s with the NINDS trials that thrombolysis took up with patients with acute ischemic stroke. And since then, there's been this constant effort to help improve outcomes in patients with acute thrombolysis. There have been trials with expedited, and of late, multiple trials with Tenecteplase. But I must, this is the seminal paper, the meta-analysis on all the thrombolysis trials done with Altiplase. And it went on to show how robust this drug was. Altiplase was helping all patients with acute ischemic stroke who would present early, including those who presented within 3 hours or those who would present between 3 to 4.5 hours, the elderly and the not so elderly, and those patients with minor strokes, 0 to 4, or those with more severe strokes. And then this was the classic Emerson curve, where we actually see that time is brain, that the earlier we treat patients, the better it is. And this is the message for acute ischemic stroke patients. Now, we all know about Altiplase, a friend of ours for the last 25 years. Tenecteplase is not really that different. It just differs on 3 protein moieties. But what it does is it makes that second generation thrombolytic Tenecteplase more fibrin specific. It increases its thrombolytic potency. And interestingly, it potentially depletes less fibrinogen systemically, which then translates potentially into better recanalization and potentially into better safety. But in my opinion, it is primarily the way Tenecteplase is administered, which is it is administered as a bolus over 5 to 10 seconds in comparison to Altiplase. That results in all the benefits with Tenecteplase. And so it results in these enormous workflow benefits, potentially, including faster DDO times at primary stroke centers, less errors in dosing because it's just one dose, less use of infusion pumps, less need for IV access. And in the Canadian system, it actually results in more efficient inter-hospital transfer with less use of ACLS versus the basic life support crew. And so those are potentially the advantages for Tenecteplase. Now, Tenecteplase has been known to us for almost, more than 20 years now. And it was almost, I think, like 10 or 15 years ago that this trial came out in cardiology with patients with acute MI, the ASCEND-2 trial, which compared Tenecteplase with Altiplase. Now, just as a caveat, the dose was used by the cardiologists for MI is really different from what we do. So Tenecteplase was given at a dose of 0.5 milligram per kilogram, and Activase for Altiplase was given at 1.1 milligram per kilogram. But as you can see, that was what they thought was an appropriate comparison. But in that large study, you can see that most outcomes were exactly similar. So 30-day mortality rates, the ICH rates, and the TNK versus Altiplase survival rates were exactly the same. There was a slight difference, I think, in peripheral bleeding, but overall, ASCEND-2 showed the comparability of Tenecteplase to Altiplase and resulted in a change in practice. Tenecteplase became standard of care for patients with acute MI when they were candidates for fibrinolysis. Now, in our field, and this was, I think, Sonia showed this, these slides with, this excellent piece of work that you guys do at the European Stroke with your guidelines. And so this was the evidence up until, say, around 2020 or 2021 with Tenecteplase versus Altiplase in acute ischemic stroke patients. And you can see we had some phase 2 studies, but overall, the number of patients and the strength of evidence that is necessary for us to answer this question as to whether we can replace Tenecteplase with Altiplase in our practice was quite low. And that's reflected in your own recommendations. We wanted to address this gap in evidence, and we wanted to do it in a very pragmatic manner. We wanted to ask this question as to whether we can actually replace Tenecteplase with Altiplase, Altiplase with Tenecteplase in our practice, in our routine practice. And ACT was designed, therefore, to actually answer that question. It was based on the Canadian Stroke Best Practice Recommendation, CSBPR as we call it, which, as I can see, is really similar to the European Stroke Guidelines. And so all patients who would be eligible for thrombolysis were eligible for the ACT trial. We managed to enroll around 1,600 patients across Canada. It was a non-inferiority design because it was really clear to us that if we show non-inferiority and robustly so if we show comparability, then because of its obvious advantages, folks would just shift to Tenecteplase. The trial had other unique elements, including its registry linkages, including its use of technology. But overall, ACT was actually able to show non-inferiority for Tenecteplase versus Altiplase. If you look at the results, you would see that it's the safety data. It's exactly the same. From an efficacy perspective, it was plus 2.6 in favor of Tenecteplase with the confidence intervals, the lower margin, as Sonia was showing, below 3 was around minus 2.6% for the delta. So this is the primary analysis. We call these the Grotta bars in North America, but actually these are the Rankin distribution. And this was the delta for the primary outcome. Rankin 0-1 was minus 2.6. And as Sonia showed you, along with the phase 2 data, we can convincingly say for this outcome that these two drugs at least seem to be similar. The safety endpoints exactly the same. And I wanted to show you these slides. Remember, this was the slide I showed you from the ASCEND-2 trial of Tenecteplase versus Altiplase in patients with MI. And look at what we showed in ACT, exactly the same. You can't actually distinguish Tenecteplase versus Altiplase for mortality. And so that was what we showed in the ACT trial. That was almost at the same time that the NOTES-2 trial came out, but was preceded by the Extend IA-TNK Part 2 study that was asking this question about 0.25 Tenecteplase versus 0.4 Tenecteplase. And in the Extend IA-TNK2 study, you could see that the additional dose or the increased dose 0.4 was not really that dissimilar from 0.25. And then the NOTES-2 study seems to suggest, if you just look at the raw data, that 0.4 might be harmful. There were obviously baseline differences in prognostic factors that might offer an explanation for why this is. But I think in the context of all that we know, and as Sonia showed in the ESO guidelines, the updated ones now, it is quite clear that the bus has passed 0.4, that we are not going there, that the dose that our field would actually move towards and is moving towards is 0.25 milligram per kilogram. And so now I come to what I think might actually be the future and what would happen next. And so you will see other trials. You are going to see the TRACE-2 trial done from China, which is asking the same question, Tenecteplase versus Altiplase. And that is going to be published very soon. You will see the ATTEST-2 trial. Keith is here, 1,800 subjects again, late to 2023. Hopefully, in Canada is when he'll present the results. And then you'll see probably the TASTE trial results, which is Mark Parsons' study, 900 patients odd. And so substantial evidence will build up this comparison of Tenecteplase versus Altiplase. And this might all lead in the year 2024 to a pooling of all this data with around 7,000 subjects. And we would, with a high degree of confidence, be able to answer this question as to whether we should actually be using Tenecteplase, which I think we should. The Canadian guidelines just recently changed, as is the European guidelines. But, for proponents of evidence-based medicine, and I am one, I think more evidence is always better. You would also start seeing papers that report on Tenecteplase in routine practice. Sonia just mentioned the Tetris registry with incredible work that they are doing. There would be, data that comes from Europe. There would be data that comes from across the world. Some of these papers already published, and they would show routine practice intravenous Tenecteplase data. That would actually help us substantiate the evidence that we have from clinical trials. There is a pediatric population. Unfortunately, it has always been the case that clinical trials are difficult in this population. But I'm hoping that as we move towards the use of Tenecteplase in the adult population, they would start seeing case series and case reports on the use of Tenecteplase in this population, and would find that the drugs are really comparable. But more importantly, you would actually start seeing more and more evidence for the use, questioning the use of whether you can use Tenecteplase in the late window. And so I think you already, trial results. And it was an interesting trial in the sense I was using pragmatic imaging. And overall, if you actually look at the Rankin distribution and the raw numbers, it does, suggest to promising results. But you will see, hopefully this year, the timeless trial results, the eternal results. These are from Australia. The Chablis T2 trial, which is Chinese, the TRACE-3 trial, again Chinese, and the Resilient trial, which is Brazil. I may have missed a couple of other trials, but the point I'm making is substantial evidence is going to accrue about the use of Tenecteplase in the late time window. Now, we in Calgary, my colleague Sheila Coots leads this study, which is TEMPO2. TEMPO2 is to test the use of Tenecteplase in patients with minor strokes with non-disabling symptoms. That trial is almost finished enrolling 3/4 of its projected sample size. But interestingly, it's also enrolls patients up until 12 hours from acute stroke onset using more pragmatic imaging mostly. And so that trial would potentially substantiate the evidence, not just in minor strokes, but add to the evidence in the extended time window. This is something I think is a question for the future that cardiologists, have been trying to answer the last many years. This question about what happens when we have two really robust treatments, so endovascular thrombectomy and thrombolysis. How do they interact with each other? Now, these historically, thrombolysis came first, and it was followed 15 years later by thrombectomy. And so we do not have trials that actually fully understand how one might complement the other. More recently, we have had bridging trials, but bridging trials where in my opinion, at least with the exception of one or a couple of trials, were designed in a non-pragmatic manner because they would sort of restrict thrombolysis in the other arm, so the non-bridging arm. I feel like the most obvious question to ask potentially is bridging versus rescue therapy. You know, like endovascular thrombectomy doesn't succeed often, and when it does so, it doesn't often succeed fully, and so we should have all options open. In Calgary, we think that thrombolysis and thrombectomy are complementary, that they should support each other, and so more evidence with Tenecteplase, and there are no trials of this nature up until now, would actually be really helpful. I do think the advantages of a single bolus in a cath lab cannot be discounted. There's also this interesting result that came from the CHOICE trial, which was a phase 2 trial about the use of Altiplase post-endovascular reperfusion, and it potentially helping with microvascular perfusion. Now, would the same apply with Tenecteplase, or more so? Would we have more substantial evidence than a phase 2 trial like CHOICE? Those are questions that are being answered with newer trials. And so I see the future of Tenecteplase as across this spectrum, from pre-hospital to the emergency to even in the cath lab, that you might actually use thrombolysis across this spectrum. But we do need more evidence to actually build that case. There's also this issue about balancing risk and benefits and what I call therefore titrating dose. What do I mean by this? You know, we do give weight-based dose for Tenecteplase and for Altiplase. A person who weighs less would receive lesser dose than a person who receives more. But that is the only titration we do. But what about other risk factors? What about other signals? So what about the elderly? We do, know clearly that patients benefit from thrombolysis, but would they benefit from the same dose, or would they benefit from a slightly different dose? People who are on NOACs, this is increasingly an issue. People on new anticoagulant agents like rivaroxaban or apixaban or dabigatran, should they benefit from thrombolysis? Prior antithrombotics, dual antiplatelets, patients tend to be on these drugs when they come to us. Comorbidities like CKD, cancer, MCI, diabetes, raised blood sugar, raised BP. Many of the old Altiplase trials excluded some of these patients, and therefore we have this relative contraindication sometimes for certain indications. We can substantially build evidence in the future with Tenecteplase for many of these issues. There's also this issue of key interest to me of permeable thrombi, where I think, a whiff of thrombolysis will clearly dissolve clots. And so should we then, consider titrating doses? And so would we move towards a more personalized regimen for thrombolysis, or will we stick to a standard dose? That's an important question in our field. I've just, this is a slide I made, and you can see this table with all these various conditions where, there's some uncertainty about, thrombolysis use. The guidelines may not actually encompass all of these patients. And so this is, really interesting and something that, we could actually work on in the future. Tenecteplase with concomitant therapies. The MOST trial, the NIH-funded MOST trial, is trying to understand whether giving eptifibatide and argatroban with intravenous thrombolysis in the acute period could actually be more helpful than just intravenous thrombolysis. To me, that's a fascinating question. It's a question that, our friendly cardiologists would say, it makes sense, but we need more evidence to suggest either to benefit or to harm. We know about neuroprotection, but how do these neuroprotectants, including, the drug that we at Calgary are studying, nerenitide, through the ESCAPE Next trial, whether that would actually interact with Tenecteplase and potentially help many of our patients, possibly all the drip and shippers. There's also this question about lytic enhancers like DNase 1 or Donase alpha, and then other concomitant therapies. So there are lots of questions, as you can see, in this new era with Tenecteplase. And then there's this thing about how do we answer these questions? Would we go to a previous model? We would be doing multiple trials, and this might actually take us many, many years to answer many of these questions. Or would we adopt some of the advances that COVID has given us, including the whole concept of platform trials to answer multiple questions more efficiently, robustly, at a global scale with lots of patients and sample sizes. So that's, like into a future. And so I will stop here by quoting the great American philosopher, Yogi Berra. It's always tough to make predictions about the future, and that statement itself has so many nuances. But Yogi's always been funny. Thank you.
So I think with that, thank you very much indeed, Bijoy, for that stimulating view of current activity and what might be coming in the near future. I think thank you to all the speakers for excellent presentations. And we have about 20 minutes time to undertake the Q&A session. Thank you we've had about 500 plus participants involved in the meeting throughout the course of this evening, and a good number of interesting questions to address. In order to address the questions, I'd like to introduce two discussants, Anna Bassano, who's a stroke neurologist from Milan in Italy, and Georgios Zagoulis, who is professor of neurology everywhere and contributed to almost everything that's going on throughout the whole of ESO and all the various guidelines, and needs very little introduction. I think Diana's been perusing the questions, and we'll between us we will select the ones to address to our discussants and to the speakers. Thank you all.
Hello, maybe I can start. There were some questions starting with the Moyamoya experts, and feel free to volunteer to answer. There were some questions around how to assess the hemodynamic impairment and what is really the best method, CT perfusion, also with or without acetazolamide. So can you address this question?
Okay, thank you, Diana, and thank you for the question. I think that there are not comparative studies assessing the best technique, that it is actually performed according to the facilities of the centers. And the best evidence are regarding the H2O or oxygen extraction PET to assess the vascular reserve. But these techniques are very, very high cost techniques, and therefore the most used ones are SPECT with or without acetazolamide challenge. These techniques are commonly used, even if they seem less reliable to assess the cerebrovascular reserve. And regarding the other technique you cited, like CT perfusion or PVA, or ultrasound, intracranial ultrasound, they are less assessed and less reliable. So therefore, it could be necessary to implement a randomized clinical trial or some trials comparing the techniques to say what is the best technique to be used.
Yes, so there are also some questions around the possible role of inflammation in patients with Moyamoya. I don't know, this is more an expert question than exactly on the guidelines, but could anyone comment on that?
I don't know if you mean regarding the question on vessel wall enhancement and so on. Yes, there are some studies on vessel wall enhancement in Moyamoya disease, even if Moyamoya disease is defined as not an inflammatory disease, but vessel wall enhancement technique have been used, and with different results. Sometimes there is the enhancement, sometimes no. but there are some studies that observed a sort of prediction when you have at the baseline phase of Moyamoya, or the starting phase of Moyamoya. They observe that the vessel wall enhancement is a predictor of future cerebrovascular events. But there are only few studies and very, very preliminary, and it's difficult to say that this technique is very useful to make the diagnosis of Moyamoya. I think that if you have a vessel enhancement, you have always to think to other possible diseases as vasculitis, and you have to perform other examination to make the correct differential diagnosis.
Shall we take a Tenecteplase question, of which there are a number, but several that are of a rather practical slant. Two linked questions are, firstly, what's the position of Tenecteplase use without a license or regulatory approval? And secondly, what's the practical chance of using Tenecteplase without the drug, since we don't have drug supply in much of the world at the present time?
Thank you, Keith. These are both excellent questions. First of all, we use Tenecteplase in our center, but this is off-label use, so the patient has to sign a consent form, and this is something that we need to highlight. Also, the package instructions are for the MI dose. This is 0.50 milligram per kilogram, so we should not read the package instruction. We should be aware that the dose that we recommend is 0.25 for reasons not only of efficacy, but most importantly for safety. So these are considerations that need to be taken into account. Of course, there is a shortage of Tenecteplase, and everybody knows that. So when we are using off-label Tenecteplase for some acute ischemic stroke patients, we may deny Tenecteplase from some patients with acute MI where there is an on-label indication. I would suggest that there is strong evidence from the guidelines and from the randomized trials to use Tenecteplase over Alteplase in this scenario of shortage, only patients with LVO where there is clear evidence of superiority. However, if we don't have availability of TNK, especially in the next months, then we should stick to using Alteplase. Having said that, Boehringer Ingelheim will apply to the European Medicines Agency for a special license for the use of Tenecteplase for the indication of acute ischemic stroke at a dose of 0.25 milligram per kilogram. And I think that both the shortage of Tenecteplase and the off-label indication will be solved within the next 2 years.
We also have some questions around the equivalence of ongoing trials. This was already mentioned by Bijoy, but would you like to comment on the ongoing trials and which could be the ones that are affected?
This is a very timely question. And first of all, it's also stated in the guidelines that this recommendation should not affect the equipoise of ongoing trials. We need more randomized evidence. And I think that, as Bijoy mentioned, there are multiple trials, both within the standard time window and within the late time window, both in unselected acute ischemic stroke patients and in patients with large vessel occlusion, that will provide additional evidence. We need to keep randomizing. And I believe in the end, when the individual patient data meta-analysis will be conducted in 2024, there will be, this is my personal view, there will be strong evidence in favor of Tenecteplase superiority over Alteplase, both in unselected acute ischemic stroke patients and in patients with large vessel occlusion, provided that all these trials are finished and we have this additional data.
Shall we move back to the Moyamoya question? And I think there's a question there about the follow-up frequency that's recommended. You've made guideline recommendations there about follow-up imaging being undertaken, but how often?
Yes, there is not a clear indication on the time of follow-up, even if we know that it's really necessary to assess at-risk people, and also Moyamoya patients that have unilateral involvement that may, in a percentage of cases, progress to a bilateral condition. Normally, we do a follow-up, an angiographic follow-up at 6 months after the intervention, and after every year we do the assessment of patients, and we normally do assessment with not only MRA, we do angiography for the first years, and after with the MRA, and also neurophysiological assessment, and when we have some doubts, we add also hemodynamic studies.
Could I just see if the other Moyamoya experts would have variations, because there seems to be quite wide inter-center variability in what people choose to do. Is that sort of schema in terms of angiographic imaging and hemodynamic imaging similar to what's being recommended in other centers?
I think that it depends from availability of centers, but I don't know if the other colleagues working on Moyamoya would like to add something, but it depends from obviously from the facilities of the centers. And for instance, we don't have a hemodynamic assessment in our institute, and we have to do SPECT in a center outside. But I think that these patients should be addressed in referral centers to be cared in the best way, and to do every kind of examination that can be useful for the follow-up assessment.
Yes, I think that it's a very important point that patients will be addressed to the referral center, because in particular for perfusion imaging, there is a difficulty to analyze the data. And it's important also to be familiar with the technique we use. As Anna said, PET and SPECT imaging are the best validated techniques, but their availability remain limited in some centers. And the new technique such ISL, CT perfusion, and other one are very interesting because they are more available, but their predictive value regarding the clinical course of the disease has not yet been verified.
I can speak about our own experience. I mean, my own experience is that actually, as Dominique says, perfusion imaging techniques are interesting, but actually the predictive value is, I think, questionable. And we've tended to use a rather rough and ready clinically an MR, cross-sectional MR based approach, and really only undertake diagnostic angiography pre-operatively and post-operatively, but then so we would serially follow patients with MR at sort of widening intervals, but not repeat angiography unless there was a question about about diagnosis or further.
Yes, I think it's really necessary a combination of elements that are not only instrumental elements, but also clinical features, and the decision of other instrumental examination is based also to the symptoms of patients as well as the indication for intervention.
Still on intervention, there are some questions around selection for surgery, and also a specific question on the possibility of, in patients with bilateral disease, of indirect revascularization in both sides in the same procedure. Do you have any experience on this?
In this case, I don't have personally any experience of bilateral indirect revascularization contemporarily. I think I didn't see patients that did the procedure in both hemispheres together. I don't know if the other colleagues saw. Then regarding the indication to surgery, they are not clear, but normally you use a clinical event, a cerebrovascular event, or the presence of a lesion at MRI, watershed lesion, and the hypoperfusion, the cerebral reserve impairment, and the hemodynamic impairment. These are criteria for intervention, and also you need to do, as Vijaya stated, the angiographic evaluation, also to state the state of recipient and the state of vessel to plan the best intervention. And normally we start the side of intervention from the symptomatic side. And
Vijaya, you would like to comment as well?
Yeah.
I think you are muted.
I'm so sorry. We routinely undertake indirect surgery, so we're only operating on a pediatric population, and the technique of choice at my centre is peel synangiosis, and we've been doing that for 20-something years, and we've recently moved to undertaking bilateral surgery with intraoperative EG monitoring. But this has actually been routine practice at Boston Children's Hospital, for instance, for many, many years, which is a very high volume centre. They've been undertaking bilateral surgeries with EG monitoring.
So it might pull things back to Tenecteplase, of which there are several questions, and if I could group together a number of those, because there are several round about extending the use of Tenecteplase into other scenarios. So question about any experience in pediatric stroke, any experience in rescuing unsuccessfully recanalized patients who've received alteplase, and any experience in intraarterial use, which I suspect all have a rather similar answer.
Yes, I cannot recollect any observational or randomized evidence for Tenecteplase in pediatric stroke. I'm aware of 2 trials evaluating the intraarterial infusion of Tenecteplase. These are phase 2 trials following successful endovascular thrombectomy, having a design similar to the design of choice. And the third scenario, Keith, was post-thrombectomy, pediatric stroke, and was there a third? The
double thrombolysis.
Failed thrombolysis with alteplase. So if you've given alteplase but not recanalized, is there a role for Tenecteplase in that scenario?
Yeah, I'm unaware of any evidence with regard to that scenario. Maybe Sonia or Bijoy can pitch in and add their own information on that, but I don't know any observational or randomized trial with that in that specific clinical scenario.
No, we do not have any data about this specific scenario.
So you should be looking at Tenecteplase as alteplase, but given as a bolus. And so the question you're asking is, if alteplase doesn't work, should I actually give more alteplase to make it work? And then you run into a dose issue and therefore harm. And so that's, I think that's the way to look at this question. And so if you would do that in your practice, which I presume you would not, give more alteplase for somebody who doesn't recanalize, then I don't think you should be offering Tenecteplase.
Yeah, I want to further underscore what just Bijoy said. So, if we use Tenecteplase at a dose of 0.25, the pooled rate of symptomatic intracranial hemorrhage across randomized trials is 1.6%. The pooled rate of symptomatic intracranial hemorrhage with a Tenecteplase dose of 0.4 is 5%, 3 times higher. So when we start increasing the dose or combining different lytics, I think we're going to run into serious trouble.
Maybe again back to Moyamoya, just a question on RNF vasculopathy in Caucasian patients. Would you like to comment?
Yes,
More broad vasculopathy.
Yes, RNA 2013, as Dominique stated, has been associated to the disease, but in Asian countries, and it is really strongly associated to the disease, to about 95% of familiar cases in some studies and 80% of sporadic cases, but not in Western countries. And there are only some studies highlighting some variants that are associated to the disease, but the significance of the gene in Western countries is very low at the moment.
Okay, thank you very much. So it is now my pleasure to close this very fruitful webinar in which we had the opportunity to know these two most recent ESO guidelines and discuss important details directly with the authors and with experts. Also, we could hear these two excellent talks that really reflect the state of the art in the topics as viewed by these experts in the field. So before closing, a special thanks to the ESO Guideline Board, the model working groups and their chairs for this work, which will certainly be very useful in clinical practice. And also thank you for the speakers for the excellent lectures. And thank you all for attending and participating in this session, which was very lively discussion. We hope to see you in Munich at ESOC, where we will be able to continue this discussion around these guidelines presented today, and also where more guidelines will be presented. So have a nice evening. Thank you very much.